All right. Welcome, everybody. Good morning, good noon, good afternoon from wherever you're joining us. Very, very excited to do something a little bit different today. Um, as you may have seen occasionally posted on YouTube, we have internal sessions in the CPS that are as diverse as as the members that we have, meaning that we have all sorts of internal sessions that we do. I'd say on average, anywhere between, I don't know, 10 sessions, 10 to 15 sessions per week, but they're diverse in that they can look like anything, meaning anyone can present to anyone about any case, anytime. Um, but there's one sort of consistent theme, and the consistent theme is a scenario where I typically present a case that I saw to have this brain trust solve it. And there's two secret agendas. The most important secret agenda is community building. And the idea is that, we all have our videos on. I like to poke people with their videos off, even though I have my video off 100% of the time when I'm not facilitating. So it's in jest. Um, yeah, it's to build community, to chat and hang out with each other, but also, quite honestly, to prepare people for the rigor of having to share your thoughts out loud. And that rigor on the surface is something that, um, for those of you in training, you have to do all the time to your senior resident or your attending. But that actually is just the beginning because the rigor is what ultimately, when you are an independent practitioner, is the rigor required to explain it to yet another level of clarity to your patient. Um, and I think that's what we're here about, right? We're here to ultimately try to help people as best as we can. And I guarantee you, those of you who are able to articulate your thoughts clearly to your resident or attending are in a much better position to do the same in a patient-centered manner. And so this is what we do all the time. And today, we're going to combine forces with one of our Academy members, the one and only Khashar, who's returning to the case presentation slot. So instead of me doing both the presenting and facilitating, I'll just be facilitating the conversation. And so let me hand the mic to Khashar, and then we'll also shout out the people who are anchoring this session. So mic to you, Khashar, and welcome back to a Friday case presentation slot.
Hi everyone. Very excited to be here after a very long time. Sorry if my voice is kind of bad today. I'm just getting over an influenza case. So today's case is actually a double case, which
Ooh,
I'm glad we decided to go academy style with it because
yeah,
it facilitates the conversation much better.
awesome.
And yeah, let's hand the mic to people who are doing teaching points
Yeah,
and describing today.
you got it. Fahad is scribing today. Fahad, mic to you.
Hello, guys. It's my first time scribing here, and I'm very excited for the two cases that is going to be presented here. I took some liberty to change our usual VMR whiteboard,
Nice.
just so that the regular listeners know. I'm
Yeah,
excited to
oh,
do it.
you're the best, Fahad. Fahad is one of our newest Academy members who is a beam of wisdom and kindness already. Thank you for the advanced preparation to split the screen. And then I can't say new anymore. Formerly new, and increasingly deeply entrenched Manaswini is doing teaching points today. I'll hand the mic to you, Manaswini.
Hello everyone. I'm doing teaching points today. Really excited because it's two cases and it's my first time doing two cases teaching points. So looking forward to that. And of course the discussion. And it's going to be academy style. So those who are not a part of the academy, I think they'll have a treat. Yeah. So looking forward to it.
Awesome. All righty, Fahad, your advanced preparation will come in handy. Thank you so much. Feel free to share the whiteboard, and Khashar, we're ready to rock and roll.
So, I saw these cases around Halloween, but there weren't any near slots available for presentations. So I just gave them a name for the Halloween theme. The cases are called Double Barrel Horror. I will present them in five aliquots, each except for a patient, and the final one will reveal both diagnoses at the same time. So let's start with case A. The patient is an 85-year-old man with a history of ischemic heart disease and diabetes mellitus who has presented to the ED with generalized abdominal pain since this morning. The pain is progressive and continuous and doesn't refer to anywhere else in the body. There were no changes in pain in response to bowel movements, and his last bowel movement has been a few hours ago. Patient reports no diarrhea, no change in the color of stool, and no blood. There is slight nausea, but no vomiting, and the patient hasn't eaten anything since this morning. The pain is positional and gets worse with him lying down. The patient looks ill but non-toxic with stable vitals upon first arriving to the ED. He has a history of hypertension, ischemic heart disease, and diabetes. Neither him nor his sons know what drugs he uses, and we sent out one of the family members to go and get a picture of the medication he's using, so we have a history on that. All they know right now is that he takes medication for his hypertension. He doesn't take insulin. The patient is also addicted to opium but doesn't have any history of smoking or alcohol use. And I'm gonna stop there.
Oh my gosh, what a rich history. It sounds like the foreground is basically acute diffuse abdominal pain, and there's a very rich context by which to analyze it. Saket, maybe I can ask you to kick us off. When you're entering this space of focusing on diffuse abdominal pain, what kinds of thoughts start to cross your mind?
Um, hello, Dr. Rabih. Yeah, I think we have a beautiful schema for diffuse abdominal pain, especially it being acute. You
Yeah.
want to think of the emergent causes,
Mhm.
uh, which is the VMR mnemonic, vascular ischemia, perforation, and obstruction. But I'm also thinking this patient who's an 85-year-old male with history of ischemic heart disease, definitely getting an ECG and troponin just to make
Excellent.
sure it's not an MI.
Excellent.
Uh, I'm I'm thinking how the fact that it's positional will help me make
Mhm.
progress. But I don't think I can think of anything
Yeah.
particular right now.
Yeah, I'm intrigued. I'm intrigued. I love how you analyze that. You're like, what are the known causes? And the known causes are mesenteric ischemia, any itis, pancreatitis, appendicitis, perforation of the bowel, or obstruction of the bowel. But you also, I think, emphasize that there are emergencies above and below the abdomen that can sneak up on you, especially acute coronary ischemia and in women of childbearing age and ruptured ectopic pregnancy. So those are really, really key to keep in the back of your mind. But I think you're also using very powerful features of not just the pain, but the accompanying features. So the positional pain is very intriguing. You ask yourself, like, what in the belly cares about what position you're in? And the truth is that it's such a rare and unique feature that you first have to make sure that it's not a distractor. And so it might just be that the patient is uncomfortable in general, and that lying still and not moving the peritoneum is the positional component. So it's you always have to tread carefully with things that are surprising and unusual because they either are a profound clue to the diagnosis or they're distracting you. And only after we've moved past the more emergent causes should we really start to say, wait, is this a clue or just distracting me? So I'm right there with you with that analysis. Um, Aaron, maybe I can ask you to reflect on the background. So we heard that the patient has a background of hypertension, diabetes, um, and likely opiate use disorder. How were you? Actually, I don't know if the use of opium. Anyway, I'll map it onto what I know of opiate use disorder. It is probably not accurate. Um, yeah, how were you using that data, Aaron?
Yeah, so the history of diabetes and hypertension and ischemic heart disease in an elderly male. makes me think more that this patient has risk factors for like atherosclerotic disease,
Beautiful.
particularly like vascular issues, like you said,
Excellent.
mesenteric ischemia. But
Beautiful.
based on this generalized presentation, I can't really, think of anything specific other than just,
Yeah.
zooming out and looking for more features we can try to localize on.
Yeah, superb. Yeah, I have nothing to add to that. That's awesome. Um, yeah, Kashar, why don't we, you've laid a context. We have our emergent diagnoses. We have the background emphasizing one or two things. Um, I just saw your message in the chat. So I'll hand the mic to you to clarify and then maybe tell us what you have next.
For clarification, opium may not be the right translation for the substance that the patient was using,
Yeah.
but I couldn't find a better
Yeah.
translation. It's a
Yeah.
precursor to heroin
Yeah.
that is rather popular in Iran as a form of
I see.
recreational drug substance,
I see. Understood.
especially in the elderly population. And so we have our initial evaluation. We are thinking about sending some labs, maybe some
Mhm.
initial diagnostics, but another case walks in. This time, a 15-year-old male who presented to the ED with hypogastric pain. The pain has been going on for the past week. It has been continuous and progressive without referral to anywhere else. The pain is non-positional. It does not change with bowel movements or eating food, and the patient's last bowel movement was yesterday afternoon. There has been slight intermittent nausea without any vomiting for the past week. We saw the patient with his mom present, and the patient has no past medical history, no history of substance use, has a history of smoking, but no alcohol use. And I'm gonna stop there.
Yeah, awesome. Wow, I love it. Selson, I know you're probably just refreshing your neurons from very busy ICU, but I'm curious, what stands out to you as different in this case compared to the patient A that we were thinking about?
Um, so number one is the patient's age and
Yeah,
not having like the risk factors as the older
right.
gentleman in the other
Yeah.
case that has been that we have. And um, well, I would initially like start with a similar approach of like any
Yeah,
abdominal pain complaint.
yeah,
Um, what else I would say? Yeah. I would think of also things like below the diaphragm for him and
yeah.
above. Like
About-
I would start with a similar approach, I would say.
Yeah,
Um, and I
yeah,
feel like maybe one of the no misdiagnoses in as a younger age, like what is it called? Hernias and
yeah. Nice.
I forgot what is it called? Where the
Yeah.
spermatic cord I forgot.
Torsion?
Yeah, torsion.
Yeah,
Yeah,
there you go. I
yeah.
can read your mind.
Yeah,
Yeah.
in a young age like him.
Awesome. I love it. And maybe, Kasha, can I ask you to clarify? So hypogastric, is that in the left upper quadrant or is it epigastrium? When you said hypogastric, I missed that.
Hypogastric, I meant the lower quadrants, both sides,
Both sides.
left and right lower quadrants. Yeah.
Left and right lower
Suprapubic.
quadrant.
Yes, yes. Suprapubic.
Awesome. Awesome. So Selson, just to reflect back with you, so the first patient had diffuse generalized pain, and the second patient just has hypogastric pain. Does that change the calculus for you at all or not really?
Um, Maybe that would make a more like localized
Hmm.
issue. Like when I think about generalized abdominal pain, I would
Yeah.
think of things that are present diffusely in the abdomen, like the
Yeah.
peritoneum, vasculature, nerves, for example. And for example, the
Perfect.
colon takes a very
Yeah.
big space there.
Right. Yeah.
However, I feel like in the second case, uh, a more localized inflammatory process is more
Beautiful.
likely.
Yeah, superb. If you go back to what Saket said, and and he reminded us to start with just the VIPO mnemonic vascular inflammation, perforation, or obstruction. I'd love for you all to remove the I for a second and just remember the V, the P, the O, vascular perforation obstruction. And if you had asked Saket the follow-up question, vascular perforation obstruction of what? And the answer is the bowel. Acute mesenteric ischemia, perforation of the bowel, obstruction of the bowel. So the VIPO mnemonic is a bowel-based emergency except the I. The I is focal diseases, cholecystitis, pancreatitis, diverticulitis, appendicitis. So if you're making some leaps, the emergencies for diffuse abdominal pain have to do with the most important structure that is present diffusely throughout the abdomen. That's the bowel. The emergencies that are prioritized with focal abdominal pain are all the focal itises. Now, there definitely can be overlap. You can actually get focal mesenteric ischemia as an example, or you can get a diffuse itis in many ways. But the general calculus is if somebody's presenting diffusely, you ask yourself a simple question, what's the one structure that is most commonly involved in diffuse abdominal pain? That's the bowel. And what's the most common structure focally? Well, too hard. Many, many different structures, but that's when you use the quadrants. So, Vinny, maybe I can ask you when somebody has bilateral lower quadrant abdominal pain, right lower quadrant and left lower quadrant, what structures does your mind think of?
Yeah, so and it's interesting, Rabbi, because I think believe that it's important to correlate with the time. So appendicitis is more a just a unilateral thing, and it would be presented with more subacute curves than a weak. We can think about cystitis, diseases of the perineum and the pelvis. And yeah, I would go by GU, include GU, not just GI, especially in this patient. And it is important also to remember that smoking history is a risk factor for ischemia, for acute mesenteric ischemia. But then we wouldn't have like the acute thing. It would be more a chronic ischemic, or maybe this patient we need to rule out if there's any acute thing of embolization. But due to the time course, that's more low in the differential. But like anyways, on a general manner, well, just to answer, I would like include like cystitis and disorders of the pelvis.
Yeah, I agree with you. I think, Vinny, it's interesting. Whenever we say focal, it's often actually only one quadrant. So it's interesting in this case to say it's actually focal, but two quadrants. What does that mean? And I'm actually perplexed by that. And I love what you mentioned is you're unifying those by saying maybe it's an unusual presentation of appendicitis or maybe even diverticulitis with the pain sort of radiating to the other side, or you're using midline structures like cystitis, the bladder, or testicular pathology that can radiate to both sides. Um, I think, yeah, it'll be really, really intriguing to see how this case ends because focal uh, dual quadrant involvement is really, really interesting, and I think that'll be fun to reflect on. Um, yeah, just for the sake of time, there's so many things to reflect on, but I want to make sure that we have time to reflect at the end. So, yeah, both cases are intriguing. The age, the location of the pain, and the risk factors are big differences, as is the time course, with the first patient presenting much more rapidly to care with 1 day of pain compared to 1 week of pain in the young adult. Um, so, yeah, Khashar, mic to you to see how this evolves.
So, following your thoughts, you are thinking that, okay, I have time to think about the patient. He is rather stable. So, you send out the initial labs and you tell yourself, okay, let me go check on the other guy. And on initial examination of case A, his vitals were stable with a blood pressure of 110/70 and a pulse rate of 96. His head and neck exam looks normal, with the only finding being dry mucosa. His lung and heart sounds were normal. On abdominal examination, his abdomen is soft without any tenderness, rebound, tenderness, or guarding. We sent the initial labs and CT scan with VBG and EKG being the first things to come back. The EKG was normal without any suggestions of new ischemic events. The VBG was the interesting part. It showed a pH of 7 and HCO and a bicarb of 18. The VBG came back while I was with him waiting for the CT, during which he faints, has no pulse, and so we begin doing PCR.
Oi, 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 oi. Wow. Um, First of all, your storytelling is unreal. I feel like you're taking me back to the original RLR phenotype where we would do something very similar, but I think you're much more skilled at it than we ever were. Thank you, Hashar. I'm glad that you are in this situation as a trainee because I think this is the reality of practicing acute care and the vulnerability of when somebody only presents with 1 day of symptoms. Unlike the second patient, we have 7 days of stability. Here we have none. Um, but before we talk about his potential arrest, um, Mohammed, I'm really curious how were you analyzing the VBG result in this case before the patient has the unfortunate turn of events?
pH is low.
Yes.
I'm thinking about acidosis.
Yes, good.
Yeah.
Excellent.
So uh, I have this thought.
Yeah,
This patient, uh, what strikes me more than the pH is the normal abdominal exam. So the patient have a normal abdominal examination. There is no tenderness, and also have a pH of low pH,
yeah,
acidosis. So I hear this. I prioritize ischemia and
yeah,
and sepsis at this point.
yeah. Yeah, let's zoom in on that, my friend. Okay, so you said he has a low pH, and now you said he has acidosis. Help me try to apply the next label. Is this a metabolic or a respiratory acidosis? What do you think?
Since the low bicarbonate, I think it's
Yeah,
metabolic acidosis.
perfect. Perfect. And so, when you think about metabolic acidosis, how does your mind break it down further? Acidosis, metabolic, and what would be the next question that we don't have the answer to, but that is on your mind?
Um, the breakdown, there's two categories:
Yes,
high anion gap and
beautiful.
a normal anion gap.
Yeah, beautiful. And now would love to see, but just for all of you, I try to, in these facilitations, try to take people all the way to their zone of like fuzziness. And that's when I start to help them. Oh, so Mohammed, I have not found your zone of fuzziness, so I'm going to try. What is your guess based on everything else? Do you think this person has anion gap acidosis or non-gap acidosis? Based on the clinical scenario, what do you think?
Based on this patient
Hmm.
acuteness,
Yeah,
so it's acute case, 1 day.
yeah.
Uh, I think it is high anion gap.
I agree with you. Yeah, I agree with you. I'll tell you the story real quick. So all metabolic acidosis represents a loss of bicarb. The bicarb is low. And when we divide it into anion gap versus non-anion gap, it actually is quite a lazy way to approach it. And let me tell you what I mean. All we are asking is what took place of the bicarb since the bicarb is low. And it's either chloride, which is non-gap, or we are too lazy to tell you, so we call it gap. Can you imagine doing that approach for for whenever you lose something? You either say, "Oh, it's either with Muhammad or with everybody else." That's essentially what this approach is. So this whole approach of gap and non-gap is a artificial one because we often have the chloride already there for free. I've never met a lab that measures bicarb without measuring chloride. So um, the interesting thing also is that replacement of bicarb by chloride is often a physiological process as a result of impaired homeostasis from fluid losses, diuretics, diarrhea, whereas a gap acidosis or a non-chloride-based process often represents pathology. And so you're right to think that this patient who hasn't had any volume loss and had not even has a little bit of nausea, not even any vomiting, probably doesn't have any physiological reason for chloride to replace bicarb. And so you're worried about something pathologic. And so I'm right there with you. Manaswini, I know you're working on teaching points, but I'd love to tap into a reflex actually. So as if Muhammad is setting you up to prioritize anion gap metabolic acidosis, what specific molecules do you worry about most in anion gap metabolic acidosis?
So I would start thinking about the mud piles mnemonic, and I remember alcohol or uremia, and it could be ketones
Mhm.
or ethanol, methanol, and so
Sure.
on. Yeah,
Yeah.
iron,
Yeah.
salicylates.
So Manaswini, your list is comprehensive, but I think you'll see that when you have something comprehensive, it impairs you in the moment because you're like, I have to think about all these things. If you could only think about one that is the most deadly or the most morbid, which one would you think about first?
I would think about ketone bodies.
That's number two on my list. Number one starts with an L.
Oh, lactic acidosis.
Yeah. Yeah. I think lactates and ketones can be actually pretty morbid, to be honest with you. As actually, yeah, I know you were there in the case of alcoholic ketoacidosis that I presented to you, how quickly it was important to normalize the pH. But when lactate, especially with this association with mesenteric ischemia, is a really, really deadly combination. A very simple mnemonic is KLUI. Ketones, lactates, uremia, and then the I is for ingestions. I would advise you all to break down anion gap metabolic acidosis into another simple breakdown, which is the anion endogenous, meaning the body is making it, like ketones, like lactate, or like uremia, or is it exogenous, something that the patient took? And I think that's a helpful way to make progress. So I think the truth is we now have a much more serious issue to deal with, which is the patient had um, just had cardiac arrest. And just to move things along, I think the first thing you want to do, in addition to supportive care, so supportive care would be backboard, CPR, airway. Diagnostic management involves first figuring out, is this VFib or VTAC, i.e. a shockable rhythm, or is it a non-shockable rhythm? A non-shockable rhythm is more likely here given the normal EKG preceding the arrest and the fact that there's severe metabolic acidosis. And so I think no matter what, empirically giving this patient bicarb amidst the usual resuscitation protocol of presumed PEA arrest of epinephrine is going to be really key. Um, we could talk forever about that space, but I know we have a lot to get through, so I'll hand the mic back to you, Khashoggi.
So great discussion so far. We are gonna leave me doing chest compressions on patient A and see what the examination looks like on patient B. On initial examination, patient B vitals are stable with a blood pressure of 120/80, a pulse rate of 84, and a temperature of 38.3. His head and neck exam is normal, lung and heart exam is normal. On abdominal examination, you see a 7 centimeter scar on his left flank on the mid-axillary line. When we inquire him about it, he asks his mom to leave the room, which she does after some convincing. And he reveals a history of penetrating trauma, a stab wound which happened last week during a fight. He says he had gone to the hospital then, but his mom doesn't know about it, and only his father is aware of the issue. So we call up his father to come to the hospital. The rest of exam is we see on the rest of the exam we see that his abdomen is generally tender, with tenderness being focused on the entirety of the hypogastric area on both sides. His rectal exam only didn't reveal anything abnormal at this point, and I'm gonna stop there.
Amazing. Wow, Hashar, that's quite a twist. I would say a twist that Simi predicted. Simi, do you want to share out loud what you said in the chat earlier about the history?
I was just saying that since the patient is with parents, patient might not be so truthful about the history. So
Yeah. Kudos to you for recognizing that aspect and for Hashar for laying it out for us and managing it so well. I'm curious, how does the new fever and this trauma change your calculus for this young man? Oh, to you, Simi. How are you thinking?
Ravi, what was the question?
How does the fever and this trauma change your thinking for this patient?
So Ravi, we were thinking about the white mnemonic at that point, and now presence of fever makes me think more about inflammation or infection. And I would also like to ask if the patient had tetanus done in the past, because that is something we should also rule out and can be deadly. So that's what I'm thinking about.
I agree with you. I think the presence of fever really prioritizes the eye, and unfortunately, we don't see the evidence of the eye at the surface. So it would be very plausible if this patient had discharge or redness or swelling around the wound that the infection might be at the surface. So I think now you really worry that this patient had penetrating abdominal trauma and therefore has some complications related to that, be it blood or infection. So I think we try to avoid imaging in young adults because of the cumulative exposure to radiation over their lifetime. But I think with the fever and now the penetrating trauma, we really have to take a look on the inside. Um, I know, I know, Magnus. You probably would be thinking about this in real time. So let's sort of have a quick conversation on this. Um, do you think you would be giving this patient antibiotics? And if you were, what kinds of antibiotics would you be giving him?
Yeah, I think I would definitely have a very low threshold to be giving him antibiotics, and I think yeah, maybe after blood cultures, just some broad spectrum antibiotics can also maybe coverage for anaerobes because there might be an abdominal focus here.
Yeah, it's an very interesting debate. So I agree with you 100%. And I think I just want to emphasize that your indication for antibiotics would be that you have a high suspicion for an intra-abdominal infection. The only reason to give people antibiotics without confirming your suspicion is when you have a very high pretest probability. So you're like, I know the CT scan is going to show me something, so might as well start now. Um, that's different than when you have indications empirically treat somebody even before you have a suspicion when they're too sick. So we empirically give people antibiotics when they're septic or neutropenic and some other ones too. So I agree with you. I would not give this patient broad spectrum antibiotics. Why? Because you don't have a broad suspicion of what their infection is. You have a very specific suspicion that gram-negative rods and anaerobes are the culprit for their fever and their pain. And so I would target those organisms. Awesome. So we were doing CPR in one room on an 80-year-old man who has severe metabolic acidosis. We are having a delicate, intricate conversation with a young man and his father about penetrating abdominal trauma with fever and more localized abdominal pain. And all inspired by the descendant of many poets, another poet, Khashiyar here. Mike to you, my friend.
So before I tell you guys about the next aliquot, I'm just gonna say that both cases are gonna be revealed in the next one. So if you guys want to lock in the
Yeah, yeah,
diagnosis,
yeah.
for your
Perfect. Thanks,
discussion.
Kasha. Sorry, I lost track of how many aliquots we did because I actually turned Manas, I turned the screen to just see your faces, so I'm not seeing Fahad's great scribing, just so I can keep track of who I've asked. So this is a great time to do some breakout rooms because we have a good 10 minutes. So why don't we actually do a nice long 5-minute breakout room? Is that okay, Kasha? You think that's good time management wise? 5 minutes? Okay. Um, Simi, my goal is that every question that I ask everybody is easy. Uh, and so, yeah, I won't ask any of our guests questions. That's just rude. Don't encourage me to be rude to our guests, okay? Okay, let me make some breakout rooms. Um, okay, feel free to go nerd out and we will reconvene in 5 minutes or so. All right, welcome back, everybody. I hope you had fun in the breakout rooms, learned a lot. I think I was trying to figure out how to do this, and I think I probably just will share my thoughts, and then we'll have the opportunity to learn from Khashar. Um, I'd love to sort of take a moment to maybe re-emphasize some of the core learning we're having thanks to Khashar. The first is sort of having an approach to abdominal pain that is anchored in emergent causes, vascular inflammation, perforation, or obstruction. And I think he's teaching us a very powerful lesson of diffuse versus focal. Diffuse abdominal pain is often a disease of the things that are found diffusely in the bowel, in the abdomen, namely the bowel. Focal diseases are often an inflammatory disease, and I think we're seeing that second hypothesis, focality being inflammatory, play out in the presence of a fever in a patient. And I think the probability that the second patient will have an obvious source on the CAT scan is very, very high, but of course not perfect. High enough that Magnus was inclined to empirically treat him. And so that'll be an interesting thing to sort of go in. So my pretest probability of the CT scan being very, very illuminating and almost diagnostic in the second patient is pretty high. And after that comes back, it'll really shed light on the extent and severity of what is likely related to his trauma. But as we've learned before, um, that the trauma may be completely coincidental. And it may be that the patient was feeling very sick and having problems, um, and then develop these issues. So that's going to be really key to hold on to. Question is, if we are able to resuscitate the first patient and make that trip to the CT scan, what will it show? And as we said, the most important thing is, and diffuse abdominal pain is diseases of the bowel. So did his bowel perforate? Did he have obstruction? Or did he have mesenteric ischemia? And I think the pH and the lactic acidosis would suggest that the patient might have extreme mesenteric ischemia, and that's possible. However, developing such extreme mesenteric ischemia so quickly and so abruptly would be unusual. And I worry that the patient might have a type B lactic acidosis. And you can see how many inferences we're making. We don't even know the nature of the anion gap. We might be lactase ketones, might be something else. But I think I'm most worried about this lactic acidosis being disproportional, presumed lactic acidosis being disproportional to everything else going on. The patient has had normal vital signs, so on and so forth. And so whenever you have a lactic acidosis that is extreme or disproportional, it may be from an ingestion. So, and there are two potential inroads to an ingestion for this patient. The first is that he has diabetes, and we may or may not know whether he's taking metformin, which we learned in an academy session from Tansu causes severe lactic acidosis. Or we may or may not know whether he's on an SGLT2 inhibitor, which can cause severe ketoacidosis. It's also important to recognize that one substance use disorder often implicates the presence of another. And so co-ingestion with methanol would be another culprit here for the possibility of severe lactic acidosis. So if you're adjusting your pretest probability, you have to be careful. Pretest probability doesn't mean you don't get the test. Both patients, I think, need a CT scan. But my sense is that the patient with focality is more likely to have a positive CT scan. And even though the bowel is on the hook for diffuse abdominal pain in most patients, the disproportionate lactic acidosis suggests an ingestion, and many ingestions cause diffuse abdominal pain by their presence diffusely in the belly. And the examples we see in daily life are DKA, of course, with the substance being ketones, opiate withdrawal with diffuse abdominal pain, cannabis causing cannabis hyperemesis. So I would say my sense is that the CT scan of the patient, number one, may not be as illuminating, in which case it becomes a question of what's the substance on board if we ever get clarity on that. But Mike, to you, Khashar, to teach us how this case evolved and what you learned from it.
So this has been a great discussion so far on both cases. We were pretty much following you guys throughout our thinking, but both cases kind of surprised us with twists coming from places we didn't think we were going to see them. So for patient A, he comes back after about 15 minutes of resuscitation. And the team decided to immediately move him to the OR for resuscitative surgery and salvage uh, laparotomy to kind of save the patient and schedule him for a second look the day after if he makes it through the night. During surgery, the diagnosis was revealed to be a perforation of the stomach. We don't know why the patient was perforated, and unfortunately, we didn't get to do the second look surgery to see if there were anything else wrong with the patient, as he unfortunately didn't make it through the night. As for the second patient, when his father came into the ED bringing with himself the records from the other hospital that the patient had gone to in the previous week after the trauma, we saw that the report of the CT scan done there revealed a grade 2 laceration of the spleen with fecaloid content in the abdomen. What was interesting was that after we asked his father about the hospitalization there, he said that he was discharged with a prescription of antibiotics and a recommendation for follow-up in a few days for them to take out the sutures. But nothing about any surgeries performed there or anything else, just suturing of the wound and antibiotics. After seeing the CT scan results done in the previous hospital, we decided to also move him to the OR for an explorative laparotomy, which revealed pus and fibrin in the abdomen with adhesions between the omentum and the stomach and a hematoma behind the spleen. After surgery, he was moved to the ICU and discharged feeling well after about 4 days. So, yeah.
Wow, I mean, a tragic outcome. The same pathophysiology, a compromised bowel lumen, one of which happening spontaneously with a tragic outcome, the other happening through external trauma. And two really, really illuminating cases of abdominal pain, Khashar. I'm curious what your reflections are and what you learned from these experiences.
So, what was interesting to me about the first case was upon initial examination, there was no tenderness, but the abdominal pain preceded him coming to the ED. So, I never unfortunately got an answer to that. A possible answer could be uh, neuropathy from the diabetes, but I'm not sure if that has all of the answer that I was looking for. And as for the second case, what was interesting to me was how the diagnosis was missed in the previous hospital because we got the report from there, and I'm not sure if you would discharge a patient with fecaloid matter in their abdomen. So when we called them up to see what had happened there, understood that the report usually comes out after 3 days, and the initial management plan was done based on the physician's reading of the CT during which he had missed the fecaloid matter, which again was an interesting development of the case. But I thought both of these cases in tandem could be an interesting discussion of abdominal pain in general, which I love the discussion.
Yeah, I mean, thank you for setting us up for such a rich comparison and contrast between the two patients. And I think to answer some of your questions, going back to what Saki had said. So remember, Saki said, why is this positional? And I think it goes to show you that one interpretation of peritonitis is that the patient doesn't want to move. And so motion creates worsening of pain. And I think that's rare um, to have that be an observation, but I think it really reinforces that concept of the rigid abdomen, the patient not wanting to move it. Spontaneous perforation of the stomach often reflects the presence of peptic ulcer disease, but doesn't help you clarify the nature of the peptic ulcer disease. It's just as likely to be NSAID-induced as it's likely to be malignant in nature. Um, and so, yeah, I think this is unfortunately a very, very dreaded and serious complication of peptic ulcer disease. So my suspicion would be that the underlying cause was probably a perforated peptic ulcer, either of benign or malignant nature. I think both cases illustrate to you that the savvy and wise approach to patients with abdominal pain is not to hem and haw about what they could have, but to hem and haw about whether or not to get a CT scan. And oh, we could just you could have spoiled these cases by telling us the moment the patient comes in, they get a CT scan and then you have an answer. Both cases, right? They're effortless in that. So really the astute approach to abdominal pain and it requires you to fine tune one key thing in the modern era, which is who do you get a CT scan if you have that available? And it goes to show you how difficult it is to diagnose these things without a CT scan. Very, very difficult, to the point where historically exploratory laparotomies were done, as was the case in your first patient. Um, and so we'll have an academy session or two to reflect on, well, how do we refine that? Because if you're getting CT scans willy-nilly for no good reason, quote unquote, then you're delaying care, exposing people to unnecessary tests, radiation, incidentalomas, unnecessary findings. But if you're not getting it quickly enough in the people who need it, you can have tragic outcomes, as I think you share with us today. So there are a lot of small things to learn, but I will share you the big picture view is in patients with abdominal pain, you first get an EKG in everybody. You then get a post-void residual bladder scan in people at risk of bladder diseases. Those take 2 minutes. And then you decide, who do I need to scan? And if you get that decision right, you will get most abdominal pain right. And so I really, really think that that's sort of my simplified takeaway from your beautiful set of stories today. But Manaswini's been working hard over the last hour to prepare teaching points. So before we hand the mic to her to summarize, this big, big, big shout out to Fahad for scribing 2 cases for the first time. It's a really, really nice job, Fahad. Thank you so much. All right, Manaswini, the mic is yours.
Amazing case and presentation. There's so much learning. So summarizing what Dr. Rabih taught us, abdominal pain, we think of VPO, vascular inflammation, perforation, and obstruction. But it's important to see if it's diffuse or focal, and VPO would indicate diffuse involving the bowel, and I would indicate focal, maybe diverticulitis, appendicitis, and so on. It's important to rule out emergent causes first and then see if the patient also has positional pain associated with it, with his presentation. And it's important to think of ACS and emergent ruptured ectopic that's above and below the diaphragm. These are other emergent causes. And when we were interpreting the VBG, the usual instinct is to think about whether it's anion versus non-anion gap. But what replaces the bicarb? It could be chloride, which might indicate a physiological process unless the patient is on diuretics. Or it could be a pathological cause if chloride is not replacing the bicarb. And the molecules that would cause the gap, the simple mnemonic would be KLUI, the most important being lactate in this case as well, ketones, uremia, and ingestion. So another important question to ask is if it's exogenous or endogenous cause. And in this case, we saw that the pH and lactic acidosis and the lactic acid was disproportionate to his vitals. And if we see disproportionate lactic acidosis, it's important to think of ingestion, which may be metformin if the patient has diabetes, or SGLT2 inhibitors causing ketoacidosis, or a co-ingestion with methanol. And it's important to note that ingestion causes diffuse abdominal pain as well. Other causes being opiate withdrawal, DKA, cannabinoid ingestion, and so on. And in this patient, it's also important to replace bicarb, even though apart from resuscitating the patient. In case two, we saw that there was hypogastric pain, and this may be due to an unusual presentation of appendicitis and inflammations of organs and so on. And this would, in the presence of fever. So there was high suspicion to find something on imaging due to focality of the pain versus if the patient had diffuse abdominal pain. And on approach to giving antibiotics to this patient, first it's important to any patient. First is it's important to ask if we have a high suspicion. If we don't, then think it's important to note high pretest probability if the patient is septic, neutropenic, and so on. And in this case, it would be gram-negative and anaerobes to be targeted rather than giving the patient broad spectrum antibiotics. And case one versus case two, we saw that there was difference in age, older patient versus younger, and the time course of the presentation and the symptoms, the quadrants involved and the symptoms associated with it. And it's important to ask, who do you want the CT scan done for? And to summarize the whole class, to get abdominal pain right, repeating what Dr. Rabih taught us, it's important to get EKG, post-void residual bladder scan, and then asking yourself, who do you actually want to get the CT scan and imaging done for? Thank you.
Sandy, can I ask, how does it feel to do teaching points now compared to when you first did it?
I feel really good because when like it feels like my thoughts are more organized, and yeah, it's always amazing to do teaching points when you teach, Dr. Rabih.
Yeah, I feel like both you and Fahad really symbolize joining the academy and the growth that it happens. And Fahad didn't share his medical growth, but I think you're seeing the work ethic to prepare the slides beforehand and describe so ferociously well. And I distinctly remember, Manaswini, your explosive onset into the VMR space with your case presentation and your dedication for so many months. And I hope, yeah, I can very easily see how much you've grown with the deliberate effort that you're doing. And I think that applies to everybody. I mean, think about what everybody just did. They just like spontaneously, without any forewarning, except 2 seconds, sharing their thoughts on two difficult cases at the same time. Really, really proud of all of you, and just emphasize that this is a space that is really just all about demonstrating that desire to learn and grow. And hopefully, everyone here who's joined us live will follow in your footsteps and present cases and hang out with us, and we can further our knowledge collectively. Biggest shout out though to Khashar for what he just pulled off. It's not an easy thing to storytell the way he did. So thank you so much, Khashar. All right, guys, have a great rest of your day. Thank you.